Assalamu alaikum. My name is Tara Sumru, roll number 165. The topic of my presentation is hepatitis B. Hepatitis B is a life-threatening liver infection that is caused by hepatitis B virus. It is a contagious disease. That means it can be transmitted from one person to the other. Hepatitis B is of two types. It is divided on the basis of time duration of the disease. In case of acute hepatitis B, the patients get sick for a few weeks and it can go up to 6 months. And in case of chronic hepatitis, disease progress to serious health problems, including liver damage, cirrhosis, liver cancer, or even death. The symptoms, some people have acute illness with symptoms that last several weeks, including fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, dark urine, clay-colored bowel movements, joint pain, jaundice, that is the yellow coloration of the skin and eyes. The virology of hepatitis B. The hepatitis B virus is a double-stranded DNA virus infecting the hepatocytes. It evades the immune system in early phase of infection, and its genomic template resides in the infected cells even after the clearance of infection marker. Transmission. Hepatitis B is most commonly spread from mother to child at birth. That is called prenatal transmission. It is also known as vertical transmission. Hepatitis B is also spread by needle stick injury, piercing, and exposure to infected blood and body fluids, that is saliva and seminal fluids, etc. Hepatitis B may also be transmitted sexually. And in addition, infection can occur during medical, surgical, or dental procedures also through tattooing or through the use of razors and similar objects that are contaminated with infected blood. Pathogenesis. It is similar to that of hepatitis A virus, and the clinical observations suggest that host immune responses are more important than virological factors in pathogenesis of liver injury. Basically, this immune response is linked with the T lymphocytes involved in the clearance of virus from the hepatocytes causing liver injury. Diagnosis. Laboratory diagnosis of hepatitis B infection focuses on the detection of hepatitis B surface antigen, and these all are the infection markers of the hepatitis B virus. The serological studies shows that the acute hepatitis B virus infection is characterized by the presence of hepatitis B surface antigen and immunoglobulin M antibody to the core antigen. During the initial phase of the infection, the patients are also seropositive for hepatitis B early antigen. Hepatitis B early antigen is usually a marker of high levels of replication of the virus. The presence of hepatitis B early antigen indicates that the blood and the body fluids of the infected individual are highly infectious. And the chronic infection is characterized by the persistence of hepatitis B surface antigen for at least 6 months. And the persistence of hepatitis B surface antigen is the principal marker of the risk for developing chronic liver disease and liver cancer. Now, the clinical management. General goals of hepatitis B virus treatment is to reduce the hepatitis B virus DNA and normalize the alanine transaminase. The normal levels of alanine transaminase in the males are 29 to 33 international units per liter, and in females, it ranges from 19 to 25 international units per liter. And we have to reduce the hepatitis B early antigen, and we have to also reduce the hepatitis B surface antigen, and to reduce the likelihood of the cirrhosis, and to decrease the morbidity and mortality rate. The criteria, these two are the criteria for the treatment. It includes the patients with active hepatitis B virus and the high alanine transaminase level should be considered for hepatitis B virus antiviral treatment. And the patients with inactive hepatitis B virus may need hepatitis B virus treatment in certain situations, such as if they are immunosuppressed or treatment for chronic hepatitis C virus. These are some drugs which are recommended by WHO. The first line drugs include tenofovir, alafenamide, and tenofovir disoproxil fumarate, antisavir, and PEG interferon. And these three are the oral antivirals, and the PEG interferon is the subcutaneous interferon. And the second line drugs include lamivudine and adifovir. This chart is the summary of pharmacological factors of the antiviral drugs. And in this drug, TAF, is administered orally, and it does not has any food restrictions. It means it can be given with food. And the adverse reactions include the depression, high cholesterol, diarrhea, nausea, and headache. And it does not need any dose adjustment if the creatinine clearance is less than 50 ml per minute, but this drug should be avoided if the creatinine clearance is less than 15 ml per minute. And it should be given to the patients who are ADV resistant or ETV resistant. And the TDF is the oral drug, and it does not has any food restrictions. And the adverse reactions are similar to the TAF, and it only includes the bone mineral density loss and nephrotoxicity. And it requires the dose adjustment if the creatinine clearance is less than 50 ml per minute. And it was also given in the ETV or ADV resistant patients. And now ETV, it is also oral, and it has to be given on an empty stomach, and it should be given before or after meal, 2 hours before or after meal. And the adverse reactions associated with ETV are headache, fatigue, dizziness, or nausea. And it needs dose adjustment, and it is also administered when the patient is ADV resistant. Now the PEG, this PEG interferon is the subcutaneously administered drug, and it does not has any food restrictions, and it causes the adverse reaction associated with this are neutropenia, leukopenia, and myalgias, anemias, and weakness, skeletal pain, etc. And it also requires the dose adjustments, and the patients with high ALT or low HBV DNA require the administration of PEG. Now the 3TC, it is also administered orally, and it does not has any food restriction, and the adverse reaction associated with this are pancreatitis or neutropenia or insomnia. And the dose adjustment is required here. And now the ADV is a oral. It is also an orally administered drug. It does not has any food restrictions, and it can cause the adverse reaction associated with the ADV are abdominal pain and nephrotoxicity, etc. The for the pre-treatment assessment include the host liver injury is assessed with the temporal pattern of serum level of alanine aminotransferase, and we need to check the patterns of ALT, and next to assess the virus activity, and finally we assess for the presence or absence of cirrhosis. For the assessment of compensated cirrhosis, liver biopsy is the gold standard but invasive, and there are also a non-invasive methods also, fibro test and transient elastography. And the clinical symptoms such as ascites, hepatic encephalopathy, or variceal bleeding and jaundice indicate decompensated cirrhosis. This is the summary of WHO recommendation In this, the decision to initiate antiviral therapy is based on an assessment of fibrosis, serum, ALT, and HPV DNA. This is the case study. Here is a patient, a 52 years old person, was planned for laparoscopic cholecystectomy and was incidentally detected to have hepatitis B virus infection during preoperative workup. The history of the patient shows there is no previous hospitalization or there is no addiction. And following are the questions we need to answer for this patient before starting antiviral drugs. What test should be performed? There are some tests. We performed some tests for the investigation of the disease. It includes that his liver enzymes are elevated and the HBV DNA was low, but ultrasonography abdominal shows that features of chronic liver disease or cirrhosis. According to these results, we concluded that the patient has liver cirrhosis as the aspartate aminophosphorate to platelet ratio index is greater than 2, and the treatment we will recommend antiviral treatment for this disease, and the WHO recommended drugs are antisavir 0.5 milligram once daily oral and or tenofovir 300 milligram once daily, and the patient required monitor for efficacy and decompensation and liver cancer, and renal function test should be performed, should be monitored if the patient is using tenofovir. These are some take-home messages by the World Health Organization for the management of the hepatitis B. Cirrhosis must be looked for in all hepatitis B surface antigen positive patients, and in patients with cirrhosis and detectable HBV DNA, and in patients with the cirrhosis, antiviral treatment should be continued for life. Prevention. The most excellent result has been obtained by vaccination, and this is the best mainstay for the hepatitis B prevention. And the population recommended for the hepatitis B vaccination includes the people who frequently require blood or blood product dialysis, patients and recipients of solid organ transplantations, and the people who inject drugs, or the healthcare workers and others who may be exposed to blood and blood products through their work, and for those also who travel. Uh, and there are some other prevention methods, that is antiviral prophylaxis. In addition to infant vaccination, including a timely birth dose, WHO recommends the use of antiviral prophylaxis for the treatment of hepatitis B transmission from mother to child. And the other preventive measures are implementation of blood safety strategy, including quality assured screening of all donated blood and blood components used for transfusion can prevent transmission of hepatitis B virus. Thank you.